Tom.
So, good morning, everybody. So we're going to start off with a video first, and then we're going to have a presentation by Logan Brenzel, and then a presentation by Alba Maria, and then I'm going to moderate a brief discussion. We have a panel of experts representing different points of view and perspectives on resource mobilization. I'm going to call on each of them to talk a little bit, and then if we have time, we're going to also open it up for some questions and answers to the audience. So we start with the film now.
Three, two, one. Let's talk numbers again. How much does the world spend on health each year? $1 in every 100? 5? No. According to a new report on global health spending published by the World Health Organization in 2015, the world spent close to 10% of global GDP on health. That is $1 in every 10 invested in health, for instance, to pay for health workers, facilities, or medicines. Piled up, that 1 in 10 amounts to $7.3 trillion. It sounds like a lot of money, and it is. What's more, it's getting bigger by 4% every year between 2000 and 2015. And it is increasing even faster in poor countries with a 6% growth per year. In fact, what people call the health economy is growing faster than the global economy itself, which expanded by 2.8% per year over the same period. But there is a problem. According to WHO, global health spending remains very unequal. For example, although more than 80% of people live in low and middle income countries, they see less than 20% of total health spending. That means that many people across the world are at a risk of falling into poverty traps because of health expenses often paid out of their own pocket. WHO estimates that this is the case for more than 100 million people each year. And another staggering figure, more than 50% of the world's population does not have access to health services when they need them. In high-income countries, 7 out of $10 spent on health come from government or social health insurance, while the other 3 come from private health insurance or out-of-pocket payments. This number drops to 5 in 10 in over 100 middle-income countries, covering 76% of the world population, leaving it to individuals to cover the other half of the cost. In 30 low-income countries, the government pays around $2 in every 10, less than in the year 2000. $3 come from external aid, which leaves people to shoulder nearly $5 of the burden of paying for healthcare. So, what needs to change? One obvious way to change things is for governments in countries that spend little to spend more. And it is clear that many of the countries that have benefited from economic growth over the past decade could be spending more. Keeping a close eye on health spending is an important part of making this happen. Better data drive better policy and improve accountability. WHO and its partners are committed to working with countries to improve the availability and the quality of the data at their disposal.
So I think that sets the tone here. We see a lot of problems with equity, with resource mobilization, and now I'm going to turn it over to Logan Brenzel, who's going to lead us through some of the main points that we're going to discuss during today's session. So Logan, please.
Great. Good morning, everyone. That was a wonderful introduction to immunization and health financing. And I think it sets the stage, as Tom said, for this talk. And I've been given the impossible task of trying to review a broad area in just a few minutes. So whatever I'm unable to drill down on, just be reassured that there's materials in the marketplace that can supplement some of this talk, as well as some of the sessions in the afternoon that you can attend. So the presentation talked about the inequities in health financing. And I believe those also translate somewhat into immunization financing as well. And I'd like, for this talk, I plan to talk a little bit about the social and economic benefits of immunization, what countries are spending on immunization, what it's really costing, and what we think will happen with the costs of the program. Some conversation around the challenges of middle-income countries and around Gavi transition, and then also talk a little bit about alternative financing mechanisms and where we're getting the bulk of our resources. So in terms of economic and social benefits, I mean, we all know that immunization is a best buy in public health. We know that it's an entry point for families into the health system. But recent studies have shown that immunization has a very high return on investment. For every dollar that's invested, $16 can come back into the economy. And if we take an even broader view of what the benefits are, it's almost a 1 to 44 ratio. So a very good investment, and ministers of finance might be interested to know about that. In a recent study that came out, we also are being able to measure the impact of immunization on poverty and poverty reduction. We know that by vaccinating a child, we don't have to spend money in the health sector to treat that child for vaccine-preventable diseases. But we've been able to measure that immunization is positively associated with a reduction in medical impoverishment in several countries. So it's a best buy, and it's something that governments should be wanting to invest in. But what is actually happening? So this slide on the left, we have analyzed all the information that comes in to the Joint Reporting Forum, and you can see that immunization spending varies according to government income, or GDP. And so the higher income countries are spending over $600 per child. But at the low income end, even though there has been some increase in the last few years, we're still spending between $8 and $10 per child, which we know doesn't cover the costs of even the vaccine schedule. The graph on the right, which is probably a little hard to see, but the main point there is that even if vaccine expenditures seem rather daunting, they're only a small proportion of government spending. So we estimate between 1% and 2% of government health spending might be spent on vaccines. So while it's not a huge amount, countries still have challenges in planning and budgeting for this. So what do we know about immunization costs? If you'd asked me 20 years ago, I would have said it costs $20 to fully immunize a child. But now I can't give you one single number. We've done a lot more work and evaluated the evidence a lot more. And we know that costs vary both across countries and within countries. Costs vary according to the delivery strategies in place, the vaccine schedules in place, and we know that costs are probably going to increase as coverage increases because you're trying to reach harder and harder populations. So while I can't give you a single number, I think we're living in the reality that we need to look carefully at kind of the range of potential costs per child. And there is a special session after the plenary that goes into more detail on this. In terms of financing the program, we know that government budgets are really the key source of financing, and that government financing of health services more broadly is the context into which immunization financing sits. And so one of the issues that has come up more and more is that financing is not only at the national level. Sure, national governments allocate to subnational levels, but more and more the operation costs of immunization programs really come from locally generated and managed resources. And so our conversation, I think, about advocacy for the program needs to shift more from the national level only to being a joined up discussion between the subnational level, engaging mayors and governors and provincial heads in ensuring that they're allocating resources toward the operation of the health services. Because we know that vaccines don't deliver themselves, it requires a strong primary health care service. We need to ensure that local governments are allocating resources to that service. So one example I wanted to give you, unfortunately our speaker from Kenya could not join us today, but I wanted to summarize some of the points that would have been made. And so devolution in Kenya, there was a new constitution in 2010, and in 2013, all responsibilities were devolved for immunization down to the county level, and they went from 8 counties to 47 counties. In this process, there was no budget allocation for vaccines and operating costs at the national level. It was all devolved to the county level. And the responsibilities were divided between county and Ministry of Health. And there was a massive movement and reallocation of staff. I think since that time, the government of Kenya has been sorting through this transition. And some of the benefits have been that devolution is closer to client and the accountabilities are closer to client. The opportunity for increased funding was created, the space was created. But some of the challenges have been, it's been really difficult to track funding. There's been some confusion around procurement, and I think the government is now working through some of these issues to try to strengthen the relationship between the national level and the subnational level. And I think this is a really important case study. And I think you might be hearing from several colleagues during this plenary a little bit more about this. Now, I'd like to turn attention to transition. From Gavi, there is a session that follows this on transition, and so I don't want to go into too many details, but transition for Gavi has been related to the co-financing of vaccines, and as countries' economies grow, the expectation has been that countries will invest more and more in their vaccines that are supported by Gavi. And when reaching a certain threshold, countries enter an accelerated phase into which they have 5 years to fully ramp up and become self-sufficient with their vaccines. Not only is transition kind of about financial transition from donor support, but it's also about a programmatic transition. It has a programmatic focus. So countries also need to be able to continue improving coverage and build their capacities. And this is something that very much is forefront of the support that Gavi is providing to countries, both during the accelerated phase and also post-transition through learning networks and through other sources of support. So I wanted to test your knowledge and to ask you in the room, by a show of hands, how many countries have transitioned from Gavi so far? If you think it's 5 countries or less, raise your hand. If you think it's between 5 and 10 countries, raise your hand. How about 10 to 15 countries? Anybody think it's more than 15 countries? Right. So the answer is 16 countries have transitioned from Gavi as of today. And when we think of transition, we think that countries are facing the graphic on the left, that it's a big tidal wave or big wave coming to them that's going to swallow them up, and how can governments possibly go through this process? whereas in fact it's been more like the upper right-hand corner for many of these countries, that it's been relatively smooth sailing, though there have been a need for additional commitment. We do have a few countries, however, that are still really trying to meet all the needs and challenges, both on the financing side as well as on the programmatic side. So true or false, countries that are transitioning from Gavi are also transitioning from other sources of financing and other programs. Raise your hand if you believe it's true. Right, so I think your general knowledge is correct. Yes, countries are facing multiple transitions at the same time, and this is occurring across the globe. But I think I'd like to kind of dispel the thought that countries are transitioning from Global Fund and Gavi at the same time. I think there's only one country that I know of that's actually going through that process right at the same time now, and we only expect another two within the next few years. There are, however, 8 countries that potentially are transitioning, going through the polio transition as well as Gavi transition. And I think this is a real opportunity for us to work more holistically, because it affects your budgets, similarly, to work more holistically and to have a more cohesive approach to this. Countries are also transitioning from IDA World Bank lending, which is the low interest lending, to maybe blend kind of higher interest lending. And this does affect how ministries of finance structure the budget, and those will potentially have knock-on effects for budgeting of different sectors, including the health sector. So it's something that we need to be mindful of in the background. Middle-income countries face challenges as well in terms of financing and sustainability of their programs. There's definitely remaining unimmunized children and much more to do there. Middle-income countries tend to lag behind others in terms of introduction of new vaccines. I think Gavi supported countries overall have a higher rate of introduction of some vaccines. And middle-income countries also face higher prices, although there is a range around that price, and there's a potential to bring it more closely in line with lower prices. So we have a remaining unfinished agenda there. So what could be some possible solutions? As I mentioned, immunization financing is situated within overall health financing, and I think there's no magic bullet for mobilizing resources and bringing more resources into the program. And there's no one strategy that's going to solve the challenge of a financing gap, except pushing more on the envelope of public financing and domestic resources. And fiscal space for immunization can be expanded through a variety of ways. The first is that governments, you saw in the video, that some governments aren't really allocating that much to health. So if there's a bigger allocation to health, there's a bigger pie, the slice of that pie for immunization, of course, will get bigger. And so we need to be in dialogue with countries around increasing the overall resource envelope. Allocation within the health sector, though, is something that even today, 30 years on from looking at the most cost-effective interventions where governments should be putting their resources, we still finance curative services much more than we do preventive services. And so getting the priority setting better and more aligned with needs, investing in preventive services like immunization so that we don't have to use resources in the curative sector is really important. I think another important point is that we need to use the resources that we're given for immunization. Often at the end of the year, we're not expending the resources, and then turning around and asking for more. I'm sure some of you get the questions, well, you know, you didn't spend the money you got last year, so how can you justify asking for more resources? We also need to be using our resources more efficiently and managing them better. And so there's no magic bullet to this. It's hard work, but this is where most of the resources for your immunization program will come from. There are some innovative financing mechanisms out there, and I would just say often the cost of trying to set those up and to do alternative sources of financing far outweigh the cost or what you actually get in return. And so countries really need to be very careful when they go down this path of being able to justify and know that they're going to get more of a return on all of their effort to set something new up. And then I would say as a last resort, you could always ask the Ministry of Finance for more money, but it is a last resort. And I think for immunization community, we tend to think, well, we just go there first. But the Minister of Finance is just going to turn to you and say, well, why should I give you more money? I've given you a lot of money, you just haven't utilized it correctly. And so I think we just need to be mindful that we need to do as much as we can with what we have before trying to source additional resources. And this guide, which is available in the marketplace, outlines some of the alternative sources of financing. Many of the countries in the room have a social insurance or are pursuing a pooled financing, which was one of the solutions to the problem of the inequities in financing raised in the video. And this is part of universal health coverage. But you may not realize that as part of that process of developing and expanding social health insurance, a benefits package is defined up front of what the social health insurance coverage fund will cover. And if vaccines aren't in that package, then you lose out on that potential source of financing. So it's really important for folks in the room to realize that you need to be connected to these other processes around financing of health services in your country. And I would just like to end on a few notes and key messages. We need to be better at making the case for our immunization program. I think primarily we need to start working more at the subnational level to ensure better resource allocation. As I mentioned, there's no magic bullet. We need to really work hard on utilizing the resources that we're given. Vaccine is the best buy in public health, and immunization programs themselves really have high value, but vaccines don't deliver themselves, and we really need to invest more in the operations cost and the strengthening of the system. So I'll stop there. Thank you very much.
Great, thank you, Logan. So Alba Maria is setting up, we've heard a couple of things, but just a couple of takeaways to remember that, you know, the complexity of the cost of the fully immunized child is really contextually dependent, and we really need to think about operational costs and getting good costing data, and particularly about getting into the subnational level and understanding that subnational costs can vary quite a bit. So now we're going to have the experience of the Latin American context. So, turning over to my colleague, Alba Maria.
I'm gonna share with you some key aspects of the financial sustainability of the immunization programs in PAHO region. We have 51 countries and territories in the Americas, and 55% of them are considered upper middle-income countries. 5% are middle-income countries, and we have only 5 Gavi countries. Among the key aspects of the sustainability, I would mention the political commitment. Since the creation of the immunization program in the region in 1977, the topic of immunization is always in the agenda of the Minister of Health every year. That means that we have political commitment, which is reflected in the financial commitment as well. As you can see here in this slide, countries have increased national budget for immunization programs, and now we have 99% of the countries financing the immunization programs in the region. Another key pillar of the immunization program has been the revolving fund, which is a procurement mechanism for vaccines and supplies on behalf of the countries in order to have lowest prices, which have facilitated the maintenance and also the introduction of new vaccines in PAHO region. And you have here 41 countries and territories which participate in this mechanism. Another aspect is the vaccination legislation in the region. 29 out of 51 countries and territories have legislation on vaccination in order to protect the fiscal space, in order to guarantee the right to immunization, and especially to reinforce the state's responsibility to provide the immunization as a public good, which is offered to the whole community in each country. And I want to mention here the night tax and the regional tax have been critical in order to support countries to develop these frameworks, legal frameworks. Countries have been able to strengthen and have very strong programs and introduce vaccines quickly, but they are also facing many, many challenges right now. We have countries with ongoing fiscal constraints. You know the situation of Venezuela, for example, which is right now in a very difficult situation with a social crisis. We have seen countries struggling paying to the revolving fund, especially for the new vaccines cost. And we have vaccine coverage declining in some countries. And also, as you already know, we have many huge outbreaks of measles, diphtheria, and yellow fever in the countries. And in order to prevent and control these outbreaks and also to maintain the measles elimination is very costly in the region. As you know, the Americas was certified as free of measles and rubella in 2015 and 16. And now we are having these outbreaks in Venezuela, which have been exported to other regions. And we have the phenomenon of migration of population from Venezuela. In addition to have many people, thousands of people living in the country, they are exporting outbreaks, these diseases to other countries. Colombia reported more than 1 million people living right now in Colombia, living from Venezuela, coming from Venezuela. Peru has reported 600,000 people. Brazil, in the border with Venezuela, in Roraima, has 100,000 people, and we have some outbreaks of measles in these areas. And then we are facing these kind of situations. Now, regarding the legal framework, countries have to update these frameworks. They are working on that, working with the parliaments in order to have some updates, because these legislation were developed many years ago. And I want to mention here the point that Logan already talked about, the health reforms that we already know that is happening in many countries. And this could be an opportunity for immunization. But for that, we need to be very present in that kind of processes. I know that some immunization API managers are not part of the group working in the health reform in countries, but we need to put immunization in their agenda in order to protect immunization and also the primary health care in general, but immunization is a key component. And also decentralized countries are also very important to have and to put this immunization program as a tracer, as a marker of those models. For that, I want to share just this slide with you, because Ecuador was in the agenda, and then we want to share with you something from Ecuador. Ecuador conducted the EPI, we conducted the EPI review last year in Ecuador, and we found that the immunization is considered a high priority in public health. They have the budget for procurement of vaccines and supplies. And they also went through a reform, a health reform in 2012, and they have now a model, an integrated health model, which is focuses on primary health care, which is very good for immunization. But when we went to the field, and we found a big gap between the conceptual model and the implementation of the model, because the resources were there for vaccines and supplies at national level. But they didn't consider resources for the implementation and for operational aspect of the immunization. And then that was a huge gap that we found, and the Minister of Health had to make a contingency plan in order to correct the situation. And another aspect that we found was the human resources. As you may know, many countries are trying to have short contracts, and especially at a local level, in order to avoid the burden of pensions. Countries, there is like a trend trying to have a short contract for healthcare workers, and then there is a high turnover of this personnel, and then has a very high cost on that, and it has implications for that. And then my message here, especially for the EPA managers, that if you are in the middle of a reform of a decentralization process, there are many opportunities there, but we need to be present. And if you are not part of that group, try to find a way to put immunization in that agenda as a priority in public health, as a tracer of any model, because it's very sensitive that the performance of any model could be measured through immunizations and indicators. But we need to find a way. If you are not there, it should be through the NITACs or other people that could help to put immunization in the agenda. And that is very important for you and for the immunization program and the implementation of the reform. In conclusion, I just want to mention that we need to maintain the high political commitment at all levels, including local levels, especially in decentralized countries. And also, the integration in the new health system models is very important, and put it immunization and building synergies with other programs. The procurement mechanism, the countries should try to find the best way to buy the vaccines at the lowest prices, but at high quality. And especially the main message here is the country ownership. Thank you very much.
Thank you very much, Alba Maria. So a couple of things, again, to reinforce it. You know, that there's a lot of success in PAHO. The legislation's really anchored the fiscal space for vaccine procurement. We've seen a lot of change in the vaccine procurement, a lot more money's going into it. However, there's some real challenges, and part of the challenges in decentralization is that EPI sometimes is not there to defend immunization spending. Operational costs, as Logan and Alba Maria just pointed out, are really important at the subnational level in ensuring those revenue streams are there. And again, these are some of the issues that, you know, as we start thinking about these things, we really need to think about how do we get EPI involved in these discussions, involved in this dialogue at the decentralized level. So I'm going to let you guys read here a little bit of a quote. This is from the full country evaluation done in Uganda, Zambia, and Mozambique. And it's about costing. But while you're reading the quote, what I would like everyone here in the audience to do is to go to www.menti.com, either on your laptop or on your smartphone, because we're going to ask you a series of questions that is going to help guide the rest of the discussion here. And we're going to ask to start off these questions on costing. So you see here in the quote that this is something that this is a synthesis, and I think many of the EPI folks here in the room will share this perception that when it comes to the costs and the operational costs that the immunization program needs, there's a misperception maybe on the part of budget people and Ministry of Finance people of what actually are critical program-specific costs. And so this is one of the things that we really think is important for you to all really understand. So I'm going to go now to our first question. And this is on costs. And these are several categories. And it's a simple yes or no question. But do you think, from the standpoint of an EPI program, that you have accurate costing data on annual costs for all 7 of these categories? And this is just an arbitrary level of... Oh, okay, let me go back to that. Sorry, the code is 107007. The code is 107007. So while you're answering this question, I'm going to call on Laura Shrimp. Laura is the technical director of the JSI Immunization Center, and Laura, whoops, we need a microphone. Can I get a couple of microphones over here? So Laura is going to talk a little bit about Kenya.
Hi, thanks. Yeah, Tom asked me to speak a little bit about the Kenya from the programmatic lens, and it's unfortunate that we don't have Dr. Tabu here because I'm sure he could fill in a lot of the questions. But just to give a little more perspective, I think, on what Logan presented and to echo some of the examples that she gave, I want to raise key 4 points that have happened out of the Kenya decentralization over the last 3 years. One was the need that was not done proactively in the beginning for guidance on financial budgeting and costing and management of resources tailored to country team needs. When they devolved from the provinces and they had been rapidly expanding to districts, so even before that, the district management of resources was still being understood in many of the districts. But then when it converted to counties, you had 47 different county management teams that all had new fiduciary management of their own systems without clear guidance on what needed to be ring-fenced and what needed to be prioritized according to immunization budgets, for example. So suddenly you had some county teams with immunization focus better than others. So Coastal and Nairobi might have better understanding of their financial resources for immunization than some of the other counties that had not either had experience in immunization or perhaps were not immunization. They were focusing on curative and buying ambulances and other necessary equipment over the preventive health services. And that became an issue where, to the second point, understanding what components of the vaccination program actually need still to have that central guidance and harmonization. Suddenly 47 counties thought they were going to procure vaccine. 47 counties wanted information on procurement for primary vaccination. It took a year to get those funds back to the central level. There were stockouts of vaccine, and that was vaccines. Syringes were a different commodity. So then, a year later, they had to go back and do the same process for syringes, because that was also being locally procured, or attempted to be locally procured. So bringing that back was also an issue in the management, and then being able to link that with the central team. The third issue, and I think Logan touched on this well, is the ability to inform local and domestic resource requests and what is needed really for those operational expenditures. And this needs to be looked at not just immunization, but preventive. And then how do you bring that in a context of universal health care if, as Alba Maria said, it's an operational, fundamental universal health care right as a bellwether for immunization. If your pro-immunization program is not functioning, you start to see where the gaps in your public health system are. And that transparency and expenditure needs to be fed back to the county health committees. If they don't know how their local resources are being spent and allocated, they can't argue also for more resources. And that was a key issue in the counties. To help that, they need simple tools that show the data on expenditure, and a lot of them do not have that resource. And then on that note, last point is the buffer for fiscal cycles. If you look at almost any country, and Kenya was very much the model of this, the first 3 months after the start of the fiscal year, you will have reductions in service delivery because there's no buffer for some of the costs that are going to need to be funded on a monthly basis, but do not get accounted for until the next cycle. So you can easily check that by seeing the reduction in outreach visits that happened in some of the counties in the first 3 months of the fiscal year, because that was the first item which there was insufficient resources to allocate. So outreach visits didn't happen, coverage went down. And therefore, trying to really have transparency into that was also a big part of the program.
Great, thank you so much, Laura. And so again, you know, the critical importance, the decentralization, there's things that should be decentralized, things that shouldn't be decentralized, but if the EPI manager is not there at the table to guide those discussions, we have a real problem. But one of the issues that the EPI manager needs to guide those discussions, and one of the things that you've pointed out here, is that you don't have accurate costing data. You don't feel you have good costing data to defend what you need and to give a good resource envelope in those discussions. So that's one critical component, but as Laura also pointed out, another critical component, of course, is knowing what should be decentralized and what shouldn't be decentralized, what things need to be centralized, and what are the programmatic implications for all of that. So I'm going to put the next question up here for you. It's the same thing. So for which of the following, that's the same categories, but for which of the following do you think you have the least accurate data? I'm just going to ask you to pick one, but we want to see for which of the following you think is the most problematic to get costing data. And while you're answering that question, I'm going to ask Dr. Henry Luz, who's a medical doctor and epidemiologist and the deputy manager of Uganda's national EPI program, to give a few thoughts and a few reflections on the experience of Kenya. Excuse me, of Uganda. I'm so sorry.
Well, thank you very much for giving me the opportunity to talk about the Ugandan experience as far as preparing to navigate the transition. One of the things that we can talk about very proudly is now that we are working with a legal framework. We have an immunization law that was put in place in 2016. And the good thing with that law is that it compels government to make sure that the environment for providing vaccines is in place. So within that law, the provision for creation of an immunization fund that should ensure availability of predictable funding for the program to procure vaccines and to conduct all other activities for immunization program. Then in 2016, we had a vaccine and immunization financing review, which was conducted, and it brought out a number of challenges facing the financing of the program. One of them is what we have just seen, the budgeting process. We did not have very good figures to put into the budgeting, and also the budgeting was mainly done from up, bottom, so there was very little involvement of the bottom level players. And then the issue of predictable funding, financing for the program, they couldn't see how the funds were predictable to the program. And even the little funds that got the program, they were not being properly tracked, so we couldn't see where the funds were coming from or how they are being actually utilized. And then challenges with accountability and human resource knowledge in managing the funds. Then we had also, in 2016, we tried to look at the vaccine delivery costs in routine immunization together with the campaigns and new vaccine introductions. And what was striking in that review was that between 2011 and 2015, the cost of delivering vaccines rose to 57% in that period, basically being driven by the new vaccine introductions and the numerous campaigns that we had. In 2017, we came up with the financial sustainability plan, looking at the different scenarios that we anticipate going forward with new vaccine introductions. So we have that plan in place. And with those documents, we are now at the level of drafting the resource mobilization framework, which should guide the country in how to mobilize the resources. And we've tried to identify the key players, the key partners who are the traditional partners, but also we identified other new partners coming on board. So that's where we are at the moment. Thank you very much.
Great, thank you so much, Henry. So again, thank you. And again, the importance of thinking of the decentralized context, the importance of having accurate data for resource mobilization, the importance of having a good dialogue with different parts of the ministry so that it gets impacted and reflected in legislation and budget allocations. So for the next question, it's again the same one. For which of these following do you have the most accurate annual estimate of costs? And what we saw in the last one is that, interestingly enough, and probably see if it comes up, but what's interesting is you feel like you don't have good information on social mobilization, advocacy, program monitoring, evaluation, supervision, and also on surveillance. And these are all absolutely core, critical functions that you have to defend your budgets for. As Logan was pointing out and Maria Alba was pointing out, not only do you have to defend it in the legislation and the budget allocations, but you have to defend it at the subnational levels where there's getting resource allocations are being handled sometimes by local authorities. So what are we doing about this, and what are we going to be able to do about this? So let me just, we're doing this as a bit of a cross-check. So here we're just asking you, which of the one do you think you have the most accurate costing information for? And think about your last budget cycle. In the meantime, I would like to go to Folaki Olianka from the JSI Immunization Center. She's the immunization team leader, and she's going to discuss a little bit about Nigeria.
It can be argued that Nigeria has the highest number of unimmunized children. It can also be argued that Nigeria has one of the largest economies in Africa. The other side of it is that Nigeria in 2017 budgeted just 4% for its health budget. This is very far cry from the Abuja declaration of at least 15%. We also know that there's a very heavy dependence on donors and external funding for immunization programs. Now, having said that, I think you can kind of correlate what we're seeing in terms of numbers of unimmunized children for various reasons. But let's focus on the financing. It's a decentralized system. So the states and the local governments can equally commit funds and budgets for immunization, for health in general. But how much of that is really happening? So remember I said that the national health budget was 4%. There are only a handful of states that budgeted more than that. Most budgeted less than that. Looking at that scenario, there are a few. Oh, the other one is the health insurance. Health insurance coverage in Nigeria. Nigeria has a population of almost 200 million people. Health insurance coverage was 1%, basically. 1% of the population. So, if Nigeria is to move forward on its health agenda, and of course, immunization, improving immunization outcomes, the financing is a critical issue that needs to be changed and improved on. There are a few examples where things are happening. There's some promising practices, and I'm just going to share briefly some of what we think might help to break this cycle. One is ensuring that the immunization is very high on the political agenda. And this is at the level of the governor. This is at the level of the president. I think this is something that we're seeing in some of the states. The other thing is looking at a process that's not only budgeting against plans, but also ensuring release of the funds that are budgeted. The third element I would talk about is around increased visibility into the funding, that is the expenditure itself, an end-to-end visibility, and ensuring that that brings accountability and transparency into that whole process. So there are a couple of states that we're looking at using an instrument with a memorandum of understanding. There are 6 of them, which is a partnership with the Gates Foundation, Dangote Foundation, the state governments, and 2 of these states, USAID is also a partner on the MOU. And so these are some of what is being put in place, the high political commitment, the lever which the MOU partners are using, which is basically you have a harmonized plan. You put your money as state government into that plan before donors will put their money in. So again, using levers within this particular context seems to be able to get the governments to release the funds that have been budgeted. The other element of it is the tracking. So ensuring that there are regular audits and there are regular reviews and the involvement of civil society as well. So having said this, again, it's very complex. Nigeria has a long way to go, but we think that these are some of the promising practices that can be scaled up and explored to address this in the Nigerian context. Thank you.
Great, thank you very much. Thank you so much. So again, we hear about the critical importance of financing, the engagement at the subnational level. The engagement of civil society is a way to help track funds, and the importance of that. And the importance of this comes up over and over again, especially in decentralized contexts where government ability to really monitor compliance with budgets is very, very weak. And having an engaging civil society can be an important friend to the immunization program. And again, it requires the immunization program to be engaged, the political commitment to really think about what you need on resource mobilization. I'm going to do it now. We're not going to do Menti for this next question. I just want to do a very quick show of hands here. How many people here think that in most countries, most low and middle income countries, total health expenditure, everything that gets spent on health, how many think at least 25% of it is produced by the local government or through national resources of some kind or the other? How many think that 25% of total health expenditure or less is national resources? Anybody? How many think it's between 25 to 50%? Okay. How many think it's between 50 and 75% of total expenditure? How many are so confused that they don't know at all? There you go. Okay, well, this was a study done by WHO, and I won't go into the details, but what's important is that the little gray pie down there, the little gray pie, which you see is about 3/4 of the pie, that's total health expenditure. So 3/4 of total health expenditure, even in the poorest countries, comes from domestic spending. Now, that's not government spending, that's domestic spending. As Logan pointed out, as you get, and the video pointed out, and Maria Alba pointed out, and a lot of our speakers mentioned, as you get lower and lower into the economic level, the increased amount of this comes out of out-of-pocket payment, user fees, and other expenditures, at the country level. As you move up to middle-income country status, an increasing percentage of it is covered by government revenues. But the critical issue is that 75 to 80%, even in the poorest countries, comes from domestic spending, which means that donor spending has to really be used very carefully and very catalytically if we're going to use anything. So when countries are talking about transition, what we have to look at is very carefully is what cost categories have donor funding really spent their money on, and where are we going to have good information, good engagement to replace that with domestic funding streams. So since we're talking about the total amount of money that's being allocated, I'm going to go to the next question, but while I'm doing the next question, I would like to ask Simon Wright from Save the Children in UK. And Simon is the Director of International Development, Policy Advocacy and Campaigns at Save UK. And I'd like to have him reflect for just a minute on their perspectives on domestic allocations to health. And in the meantime, I'm going to the next question. And, I want you to think about this while Simon's talking. Not answer it yet, but think about it and reflect on what the other speakers have talked about and what Simon's about to say. And then go to this question, okay? So I'll put it back for a minute.
Okay, thanks, Tom. I'll try and sway your voting. Tom said 30 seconds. He's just said a minute, so I'll try and go for a minute. Just one additional piece of information I think that adds to really useful information that we heard from Logan and Tom and on the video, which is WHO released new data in December showing that actually the situation is much worse than we realize. Domestic resources for health have been falling throughout in low and middle income countries throughout the MDG era. There's kind of an argument the way that aid has come in has allowed ministries of finance to move health budgets to other areas and other areas of spend. So it's much more serious than we think as we go into an era not only of transition from multilateral funds, but a real instability among donors around what they're going to fund, who they're going to fund, whether they can be relied upon. And so it sets up this enormous challenge. Now, I think for immunization, And again, as you've already heard, you have one of the strongest cases, a clear, predictable, long-term benefit, limited expenditure. You've got one of the strongest cases. But if you make that case, and it then becomes at the expense of other essential primary healthcare services, which is what we face potentially if governments are going to start picking up the bill, then that's not something we want to see. So we need to be looking at the overall health expenditure. And Falake talked about the 15% commitment. Actually, we're trying now to think, should we be thinking more about GDP? And for universal health coverage, should we be starting to say that government should be spending about 5% of GDP as a minimum of government expenditure on health, which is far, far higher than Nigeria at 0.9%, India at 0.9%. There's a real challenge to do that. And also, to keep going broader, we can't just look at health because that may take money away from other important social sectors. So we also need to be behind a call for governments to raise more revenue into the public budget. 20% is a pretty good minimum. Now, for many countries, low-income countries, that's not going to fund things. 20% of GDP, spending 5% of GDP on health, whatever they end up doing, isn't going to be enough. And that's where donor resources need to be aligned to try and support those countries that are doing what they can, but where they're going to need to rely on donor aid just to provide essential immunization and other health services.
Great, thank you very much, Simon. So, again, now I'm going to thinking of what you've heard now, and I know that this is getting a little practical, but from your point of view, what is the most difficult challenge to financing the EPI program? And remember what you've heard now. You've got subnational issues. You've got a decreasing fiscal space as domestic funding is contracting. You've got a lot of out-of-pocket payments. But you need information. You need to think about this. You know, what are you actually looking at when you think about the financing process and financing your EPI programs? So to you, what do you think is the biggest challenge? You know, is it getting the accurate budget? Is it getting disbursements? Is it mobilizing the subnational operational funding? We heard from Falaki, we've heard from other people about the importance of engaging states, importance of civil society. Is it managing multiple donor funding reports and processes? Is this really the critical challenge? Is it convincing the Minister of Health for more money when you're competing against other domestic programs? Do you feel that you're in a strong position to show the value of EPI versus other programs in the Ministry of Health? Is it convincing the Minister of Finance for more money? And we've heard about this whole thing. Or, you know, as Falaki mentioned, is it tracking what is spent to ask for the release of the remaining funds? Do we know where the funds are going? Can we prove what they're being used for? Can we show value for money for what the immunization program is spending? Can you hide the image? So just wanted to get you to think about that. And while we're doing that, I'd like to call on Dr. Samantha Ginje, who's an epidemiologist in the epidemiological unit of the Ministry of Health at Sri Lanka, to just give a couple of reflections from a middle-income country point of view that, while it's had some experience with Gavi, has really not required Gavi funding for the bulk of its immunization program, but has used it catalytically.
Yeah, this is regarding the Sri Lankan experience on financial sustainability of national immunization program. As a low middle income country, it has many competing priorities regarding the primary healthcare service delivery. But usually we are having a universal free healthcare system, both preventive and curative. That's how, but for the we are currently, our national immunization program is totally funded by government of Sri Lanka. It means our program is self-funding. But how we have achieved it is because government commitment for funding the national immunization program is ensured through a national immunization policy. In addition, immunization program is integrated into other primary healthcare delivery systems. Because of that, our implementation cost is relatively low compared to other countries. And over the years, other than that, our immunization program has proven its cost effectiveness, especially regarding in terms of significant reduction in the countries' vaccine preventable disease burden. It's also help us in quantitative terms always to justify to get the funding, especially to convince the policymakers. In addition, always we give a due consideration for financial sustainability when introducing a new vaccine. Before introduction of a vaccine, even with the Gavi fund, we always give the due consideration what we are going to do, how we are maintaining the sustainability, always we have a close consensus with the financial authorities before we take the final decisions. Then other than that, public have a lot of trust on the immunization program. Because of that, we were able to create a huge public demand for vaccination. It's also a main governing factor to get the funding support from the government. Thank you.
Great. Thank you very much. So again, it's interesting, you know, middle income country, again, many of the points are the same, you know, this political engagement throughout, the importance of and, you know, in the context where it's 100% funded domestically, still the continual engagement all the time with the national legislature, the importance of good information for good budget. But what I thought was great, and this is the first time we've heard it today, but it's critically important, is the idea of trust. The investment in trust, community trust, public trust, so that the demand for immunization is driven by the population. This is not just a supply push side where advocacy is going and trying to convince people. This is showing a real success story where the population's been really engaged. And I know in many countries we're dealing with the anti-vaccination campaigns. We're dealing with the growing anti-vaccination sentiment that's been sparked by social media. And I think these are examples where you really invest in public trust. And we went back to some of the things where you felt you didn't have good costing data. One of that is on social mobilization, on political advocacy. These are things that often get overlooked in operational budgets, and yet they're vitally important. And as we're going to the future, they're not only vitally important to make the message of immunization important, but they're vitally important to make demand grow, to have the public demand, have public confidence in immunization programs, and to have that public confidence really drive demand, and to give a counterpoint to this, not only the anti-vaccination messages, but to give a counterpoint to the messages from domestic programs that immunization isn't that important anymore because it's successful, because we have high coverage, so we don't need to spend that much in it. And we have to really be worried about this, because as Simon and others pointed out, domestic funding is decreasing, the fiscal space is contracting, and immunization can sometimes be a victim of its own success. And people forget that to maintain those high coverage levels and even exceed them requires a lot of investment. So here, I think, again, what you found interesting here is that, and I'm sorry that it's so small there, but again, it's convincing the Minister of Finance for more money, much more so than convincing the Minister of Health. So you think you can do a pretty good job on domestic things. But mobilizing resources for subnational operations, that's something that quite a few of you have identified as really a major challenge, you know? And the other one is tracking what is spent. So I think, you know, we have three challenges here. One is on the macro level, which is the Ministry of Finance, but you have two really important ones: mobilizing resources for the subnational level, so subnational engagement, and tracking where money is spent so you can show value for money. So then the next and final question, and again, I'm going to have somebody speak before me, but just to give you a teaser, what one of the following is the most important for obtaining more EPI funding? And this is asking and getting to the conclusion of our talk, but a little bit on, from your point of view, what kind of information can we as partners in the room and stakeholders help you get? Where are the areas that you think you need some more information? So I'll leave that, you know, there in the back of your mind. And right now I'd like to have Ulla Griffith talk just a little bit. No, excuse me, I'm sorry, Ulla, before, sorry, got the order wrong. I would like to have Karen Broom speak, who's the EPI manager from Barbados, and then I'm going to have Ulla speak. So, Karen, over to you.
Thank you very much. Thank you again for having me. Just a bit about Barbados and its system. The government finances the healthcare in Barbados at the public sector level. It is free at the point of access. So primary, secondary, tertiary services, it's free in the public sector. As with a lot of other countries, we're suffering from a decrease in our fiscal space, increased costs of public health care. We have numerous NCDs and then the consequences of NCDs, which is driving our healthcare costs. So things like dialysis and cancer treatments, they're all driving the healthcare costs. So the government has been looking at some research in areas to identify a sustainable long-term financing for health. But in the interim, because it's going to take us a little while, I'm going to tell Alba Maria not to worry. We have been engaging all of our stakeholders, including PAHO, and going forward, we will continue to do that. And civil society has been a very big help and assistance, and they've been making their contribution. But until we have really found what is the best long-term solution for us, what the Prime Minister has done is institute a 2.5% health services contribution. So this contribution, it is not a new platform. It is added on to what we currently pay into the National Insurance Scheme, and 1.5% is paid by employers, and 1% will be paid by employees. So on top of the taxes that we normally pay, which go into the consolidated fund, we now are going to pay a 1% from our salary, and the employer is going to be a 1.5%. And the money collected, they estimate that it should fund 25% of the hospital's annual budget. What they're saying also is that this will not go into consolidated fund, because we all know what goes in consolidated fund doesn't necessarily come out for what it's meant to. This will go directly to healthcare. So we're all very pleased about that, because we know that this levy has been identified for health, and it will go straight to healthcare. So that's where we are at this point. Thank you.
Great, thank you so much. And again, we're talking about some of the innovative, Logan mentioned some of the innovative financing mechanisms. Here's an innovative financing mechanism that's really been able to earmark or ring fence some funding for the Ministry of Health. And I think this is really important, and these kinds of examples of innovative financing are important. Just a quick segue on that, one of the things that you're hearing more and more about is taxes on sugar, alcohol, tobacco, and just to give you an idea, something to think about is, while these taxes can raise revenues, they are not meant to raise revenues. Sin taxes should really be thought of as a public health control mechanism. The idea is to discourage alcohol use, excessive alcohol use. The idea is to discourage tobacco use. The idea is to discourage the consumption of excessive amounts of sugar, which is the idea about it. So just be a little bit careful when you think about revenue-raising options and financing. There's a lot of literature out there. Look at the WHO website, look at the other partners' website, look at the World Bank. Logan's going to discuss a little bit about some resources on immunization, economics, and financing. But just there's a lot of resources for out there. So when you get involved in these negotiations, there are a lot of things out there for you to draw on. So please take advantage of it. So I have just two more speakers. I'm going to ask everyone's indulgence. I'm going to whip through it very quickly, but while they're doing it, we have one more question for you to answer. So based on what you've heard, which one of the following is the most important for obtaining more EPI funding? And this is now to give us as partners a little bit more information from your point of view of what kind of evidence and what kind of references and resources that you need. And remember, you'll all have this, all of these presentations will be given to everybody on a USB stick. So Ula, if I can just have you talk for a minute, and then I'm going to finish up with Megan O'Connell.
Yeah. Good morning. So I can see cost effectiveness is the first one up there, and I've got quite a lot of experience in undertaking cost effectiveness studies of vaccines, and I want to emphasize that the budgeting process, so cost effectiveness is primarily used to try and argue whether this is a good way to spend your money. So we're just going to think about that when we want to advocate for a good way to spend our money, it's so political. So cost effectiveness studies, in my experience, they're really only effective if you use the opportunity to advocate at the same time as you do your study. If you do a study and that publishes in a scientific journal, it's not going to reach any budgeting process. So it's largely more what you do and who you talk to compared to the result you get. I was involved in a 5-country study looking at what made decision makers decide to introduce new vaccines. So we did it in 3 Gavi countries and in 2 middle-income countries. In all the Gavi countries, it was, of course, only because Gavi offered the vaccine. And I thought it was interesting, in one of the countries, in the strategic plan, the vaccines introduced weren't actually there. The main priority was hepatitis B birth dose, but that just still hasn't been introduced. Instead, it was what Gavi was offering. In the 2 middle-income countries, it was so political. In both countries, the EPI manager didn't even know that the vaccines was going to be introduced. It was the Minister of Health. In one country, it was the pharmaceutical company that was influencing. In the other, it was just the minister needed some good advocacy at a certain time and just announced we're going to introduce these 2 vaccines. So political. It's, you know, it's great with evidence. I'm all for evidence, but you really have to, at the same time, try and manage this political process.
Great, thank you so much, Ula. And so now we've heard, because this is one of the things that, you know, we're asking for evidence, we're asking for better costing data, we're asking for research that we can give to you, but also how is that being used? And unfortunately, and as so many people have pointed out, if you're not there and if you're not engaged at the moment these decisions are happening, things can be imposed. A new vaccine introduction on the supply chain that isn't prepared or hasn't been thought through would be a disaster for sustainability and a disaster for the public health program. So, last, and I'm sorry, I should have introduced Ula Griffins, was the Senior Advisor of Immunization Financing and Health Systems at UNICEF. So thank you, Ula. So Megan O'Connell is the Senior Program Officer at the Results for Development and a focal point for the Gavi Learning Network. So Megan.
Thanks. I just wanted to quickly share one example for a topic that was raised by both of our speakers, and that's on legal frameworks to include operational costs at national and subnational levels. I wanted to share an example from Vietnam. In December of last year, the Learning Network for Countries in Transition convened 14 countries in Hanoi to understand how Vietnam is managing the Gavi transition. They expect to be fully transitioned from Gavi by 2020. In 2017, the Prime Minister of Vietnam approved the Health Population Target Program, and one of the components of this program is to clearly articulate the subnational operational costs for the country. So clearly defining which costs will be the responsibility at the subnational level in terms of outreach, which outreach is covered at central versus subnational, training, surveillance, maintenance of the cold chain, et cetera. And this legal framework was accompanied by support from the central level, or will be accompanied by support from the central level to the EPI units to plan for these costs. And what that looks like in practice is capacity building to advocate to the provincial people committees. So this combination of a legal and regulatory framework on including operational costs at the subnational level, along with strengthening the management capacity, perhaps some best practices coming from Vietnam as they prepare for the Gavi transition. Thank you.
Great, thank you so much, Megan. So in the interest of time, I'm not going to try to do much of a summary, but I just wanted to get to this last result. So this is what you're telling us, the kind of evidence that you would like to read. And again, apologies for the small print. But return on investment to immunization spending and the impact of the EPI program on mortality or morbidity. So really evidence of the value for investing in immunizations. We all know it, but as we heard in the keynote speaker in the plenary the other day, that there's a lot of people out there who really don't understand the importance of immunization. There's a lot of misinformation out there. There's just a lot of lack of awareness out there. So this is really important, and it's good. And then what came in third place here, when my eyes are giving up on me, yes, the cost effectiveness. But as Ula pointed out, you know, with all of these studies, it's not just having the evidence, it's how you use the evidence and how you use it to engage in the political process and to engage the right people who can really fight for you at the subnational level as well as the national level for an operating budget. So I'm going to ask, and again, you know, apologies for running over a little bit, but I am going to ask both Logan and Alba Maria to give just a couple of closing thoughts on the this plenary session. And I'm sorry we didn't have time for questions and answers, but I hope that at least having a diversity of viewpoints was able to give you some practical experiences and something to think about. So first, I'll go over to Alba Maria, and then I'll have Logan close up.
Yeah, first of all, I think that it was a very rich plenary with a lot of experiences, and then I would like just to highlight something. In order to have national resources, we need to change our way that we work. Even in low middle-income countries or very poor countries, they have budget for other sectors which are very high. For example, the army. And then if you go and you work with the Minister of Health and Minister of Finance and also the health commissions in the parliaments, and you made your case for immunization, you will be able to get national resources for immunization. But if we don't try to find those channels, it will be very difficult. We need to take advantage of those high, very high levels. They are the ones who decide the budget for the national expenditures in all sectors, and then we have many opportunities. But my invitation is to work with the Health Commission at the Parliament, and also working with the Minister of Finance and Minister of Health. Thank you.
Great, thank you very much. And just before we go to Logan, one of the critical things that many of you know that it's very difficult at the EPI program level, and just as your colleagues in TB and malaria and HIV in their programs, it's very difficult to influence macro-level spending decisions, macro-level decisions. But this is a great opportunity where you can partner up with colleagues from partner agencies who work in health system strengthening or work on health financing, colleagues from the World Bank, colleagues, from UNICEF, from colleagues from other partner agencies. When they come in on these large missions, when they do have an opportunity to meet with the ministries of finance and ministries of health, use these missions as opportunities to really argue the case for increased domestic financing for health in general, and ensuring that immunization is the centerpiece of that health spending, so that you're not competing against other health programs, but you're making the case that investments in health are investments in the fabric of that society, and that they deserve more funding. So Logan, I would like to leave it to you to summarize.
Sure. Well, I think we've had a lot of really good points raised, and I think all of the country-level interventions and contributions to this discussion. I think we have to keep in mind two things. One is that we need to use the resources that we have better. And I think we have to kind of get our own house in order and utilize and be more efficient and allocate those resources to their best use. I think that's the first order of business. And then we can think about mobilizing additional resources to layer onto that. My next point is that I think a lot of the examples showed that we're not in a small silo on financing, that immunization financing is lies within what's happening within the broader health sector financing, whether it be through decentralization or increasing coverage through social health insurance and other things. And I think one of the points there is that we need to be aware of what's going on more broadly within our countries, and also try to be at the table, or at least try to have access to somebody who's at the table to raise our voice within that dialogue. I'm putting up here a slide on key resources, and there's been a lot of evidence on costing and financing and value of vaccination available. And one website, immunizationeconomics.com, has a lot of that, and some of these other resources. WHO just recently launched the Observatory, which is a key resource on health spending. So I encourage you, these will be on your flash drive, and I encourage you to either look at the documents out on the tables or to download things from those sites. Thanks.
Great, thank you very much, Logan. So before I turn it over to Diana to close the session, just if I could get a round of applause for Logan, for Maria, and for all of our people here who've contributed, and my thanks, because they were all pulled in at the very last minute to fill up a program because we had a couple of cancellations, and my deepest appreciation to all of you for your generosity to share and spend some time with us. So Diana, over to you.
Great, thank you very much. Someone said to me this morning that they felt that this meeting was edutainment, meaning educational and entertainment, and I feel like that session fit the bill, so thank you to all the speakers. I thought that was super dynamic and fast-moving and very informative for me. So I'm going to run you through the rest of the day. If you all have your programs, just to know how you're going to orchestrate yourselves, we're going to very shortly go into coffee break. So before we break for coffee, we have 3 individuals coming up to do their teasers. We have a middle-income, yes, thank you, ladies, a middle-income countries teaser, the changing face of vaccine economics, and the WHO Afro business case. Can I ask the individuals to come up and do your sell? Here.
Thank you, Diana. So this session is mainly on improving financial sustainability, particularly within the context of transitioning from Gavi support. Not much to advertise for this session. Its importance have already been highlighted, particularly during the first day speeches. The Minister of Rwanda drew our attention to the importance of financial sustainability challenge. Keynote speaker Helen Rees listed increased domestic financing as the prime challenge. Domestic financing being essential for financial sustainability was one of the main take-home lessons for the immunization field from the first day's plenary session. Also, we had heard from the previous session on the importance of mobilizing resources. Global, regional, and country perspectives will be reflected, and experiences in responding to the challenge will be shared in this session, which will be chaired by Narendra Arora. We will also discuss the remaining challenges, which may give some thoughts for us for our work in middle-income countries that do not receive donor support. Session will start at 13:45, and the venue is AD 10. You are welcome.
Morning, everyone. Crispus Mayor is my name. As you may be aware, in the face of a global transition that we are already facing, the questions that data needs to answer are necessarily changing as well. We know that childhood mortality is declining, but then we have to be asking the question of how can we better measure the impact of immunization on non-fatal illness and disability. As we are increasing targeting vaccines to populations and geographies, how do we best measure the benefits and costs of different approaches to optimize impact? As external donor support declines and countries are taking on greater financial responsibility, how do we ensure that we have the right information and well-trained people with capacity to make critical investment decisions in immunization? So we welcome you to come to our session, come and we explore together these and many other questions. You're welcome. The session starts at 13:45, and all of you are very welcome. Thank you.
All right, thank you very much. We will have the third session in room AD 11, again starting at 13:45, but ours may start maybe 2 minutes before so that you have enough space, because we're expecting all of you to come to this third session. So maybe sorry for our colleagues. So, right, so since day one we're discussing how we can navigate through the transition. This session will be about how in Africa we are preparing ourselves actually to navigate to this transition. So you are already starting to think ahead. We'll have a session with different participants. I will do a small introduction on what in Africa we've done in terms of developing a business case to try to anticipate some of these transition. I think most of you responded to a survey that Patrick Lydon actually shared, and we've received quite interesting feedback from you on how you would like to see the post-2020 GVAP evolving. So Patrick will give an exclusive presentation on the your opinion and your thoughts on how you'd like to see the post-2020. We will have another interesting presentation by our colleague Katia Hernandez from HQ on how we are trying to see using this approach to operationalize these changes in Africa. So she will present a global perspective on defeating meningitis by 2030. And this has been one of the way we are going to try to operationalize this transition in Africa. We will have another presentation by Ambassador Dr. Richard Sezibera, who's the Gavi PPC chair. And he will give, and the former Minister of Health from Rwanda, will give us a perspective on how, from a country, this transition could be actually anticipated. And we'll conclude by looking in the future, actually having our colleague from Zipline, which is a company operating here in Rwanda, presenting their experience using the drones in shipping bloods products, but also engaging in vaccine. So we are already in the future. So please come to our session. It will be fun, it will be interesting, and I hope to see you all there.
Great, thank you. So coffee break, and the short sessions start at 10:45. Thank you.